Yeah, take it away, Lydia. Thank you.
Okay, thanks, Dio. It's such a pleasure being here with you all. So for the people I don't know, which is most of the people who are in Haiti, I am also an internist. I work at Brigham and Women's Hospital, and most of my, and a lot of my, I do research and I provide primary care at the Brigham. A lot of my research is on breast cancer in Rwanda, which is where I met Dio, and many of you here. And a lot of my work there increasingly is focused on breast cancer early detection and to some extent cervical cancer screening in Rwanda as well. And then a lot of my research in the US is on breast cancer screening in the US as well. So I'm excited to get to talk to you about principles of cancer screening. I don't know that much about what cancer screening is happening routinely in Haiti. And if it's okay with you all Haitian physicians, it would actually be really helpful. I might pause for a moment once I get started just to get a sense from you about what kind of cancer screening is actually happening. I know I haven't had an update on cervical cancer screening in Haiti for a few years actually. And I just want to make sure that what I say is relevant. So my hope for today is that at the end of the talk, you'll have a better understanding of the definition of cancer screening and be aware of common cancer screening tests. We'll talk about potential benefits and potential harms of screening. I'll talk a bit about the general characteristics of a disease and a screening test that make a test a good screening test. So when it makes sense to think about cancer screening. And then we'll talk a little bit more about cervical cancer screening in particular. So the basic idea, which I'm sure you're all familiar with, is that with most cancers, there's a better chance of survival if the cancer is diagnosed and treated at an early stage. So for example, when a tumor like a breast cancer is smaller with no or minimal spread. So the hope is that if you screen someone, you'll be able to detect that cancer when it's at an earlier stage and potentially save the patient's life. Screening is testing for a specific disease in someone who does not have symptoms, and that's a really important distinction. So it's screening is not early diagnosis of symptomatic disease. So this is just to demonstrate how important stage is to predict survival. So these are data from the United States that just show that how much better survival is when a cancer is diagnosed at a relatively early stage. So 99% of women in the US who are diagnosed with localized breast cancer, so breast cancer that has not spread to the lymph nodes, for example, 99% of those patients are alive at 5 years, compared to only 29% of patients who are diagnosed with metastatic disease. So there are two potential benefits of screening. So one is that screening could detect a cancer when it's still small. So it's present, but causing no symptoms. And that is what we hope to achieve with mammography screening, for example. So we're trying to find a breast cancer that is not yet palpable. A woman and our clinician cannot yet feel it, but it can be seen on the mammogram, which, as you know, is an X-ray of the breast. The other possibility is that screening could detect and treat pre-cancers before they become cancer. So cancers that have started to show abnormal growth, but are not yet invasive. And the most common example of this, of course, is cervical cancer screening, though colonoscopy screening for colorectal cancer is also an example of this if we find an adenoma that could potentially become a cancer later. If we find and remove that adenoma, then we prevent it from ever becoming a cancer. I can't see people's faces, but are there any questions so far?
No, it's clear.
Okay, great. So, and one thing that I want to just kind of clarify, so option one, opportunity one is finding an actual cancer when it's very small and asymptomatic. Option two is actually prevention. So this is when screening can be preventive. So we're preventing development of a cancer by detecting a precancer. And we've seen profound impact of cervical cancer screening through Pap smears in the United States, with about a 60% reduction in cervical cancer incidence, because we have actually prevented pre-cancers from becoming, so pre-malignant lesions from becoming cervical cancers. And we've seen a big drop in both cervical cancer incidence and cervical cancer mortality over the past 30 years in the United States. I want to just mention, we all hear a lot about population-based screening as opposed to opportunistic screening, and I think that that's just an important concept. So population-based screening is a systematic approach to screening that occurs when you identify a target population and you aim to screen every single person in that target population. So that might be screening of cervical cancer screening for all women from 30 to 49. In population-based screening, you have an organized, systematic approach to invite everyone in your target group to receive the screening test. The population-based screening approach must have a strategy to make sure that everyone with a positive test gets further evaluation or treatment. But population-based organized screening is a system that includes strategies for follow-up of everyone with a positive test. What we commonly do in the United States is opportunistic screening, which essentially means is screening that happens just when someone shows up at the doctor's office. So I, as a primary care doctor in the US, typically do a lot of opportunistic screening. I see many of my patients every year. I look at the list of, I do have an electronic medical record. I look at that tells me what screening tests they're due for, and I order those tests. But I haven't proactively, I typically don't proactively look across all of my patients and say, oh, here are all my 40-year-old women who need a mammogram. Let me order mammograms for all of them. That's changing in a lot of health systems in the United States, but historically in the United States, a lot of what we've done is opportunistic screening. And there's some evidence that opportunistic screening is much less effective than organized population-based screening in terms of engaging your target population and screening in an effective way. So I want to talk a little bit about mammography screening. My understanding is that in Haiti, there's not widespread access to mammography screening. Is there some mammography screening that's happening, for example, in cities?
Yes, in fact, we do have a few facilities that can perform mammogram. I'm not sure they are used per se for screening. Like you said, when someone comes in, I think they are more used, and what I'm saying now is not based on data, but I think they are more used to, to do exams for people having symptoms. I'm not sure that there are a lot of physicians out there that will order screening for, yes, if they're looking for a cancer or if there are no symptoms. That can happen, but probably fewer.
Great. So yeah, so they're doing like diagnostic mammography, but not screening mammography.
That would be my sense.
Yeah. Okay. So it's probably worth spending a little time on mammography because there is probably a lot of interest in it, and there's a tremendous controversy, as you probably know, about mammography screening in the US and Europe as well. So current guidelines, so mammography is an X-ray of the breast. Mammography screening is done of both breasts. If it's a diagnostic mammogram, they may just do the, they typically will just do the breast of concern. In the US, current recommendations are that average risk women, so women who aren't at high risk of developing breast cancer for whatever reason, should receive a mammogram every 2 years between the ages of 50 and 74. Because of, so in the past, like in the 90s and 2000s, recommendations were that we should screen every woman every year starting at 40. But because of increasing recognition of some of the downsides of mammography screening, we've really pulled back on routine screening, and now we start later and we do it every 2 years. There are increasing efforts to tailor screening plans based on a woman's risk of developing breast cancer. And that's because if a woman has a higher risk of developing breast cancer, she is more likely to experience benefit from the mammogram and less likely to experience harms. And we'll talk about some of those benefits and harms. So increasingly, we are trying to routinely assess our patients' breast cancer risk, screen them earlier if they're at higher risk, screen them later if they're lower risk, screen them less often if they're lower risk, more often if they're higher risk, to try to find the optimal ratio of benefits and harms. But this is really complicated, and it also makes a population-based screening strategy more challenging. Clinical breast exam screening for breast cancer is the screening that's more widely available in lower income countries, as you know. And we have much less data. So mammography screening has been shown to reduce breast cancer mortality in large randomized clinical trials. We have much less data about the benefit of clinical breast exam screening, but there are some studies that do suggest that it can help prevent breast cancer deaths. And most recently, the data come from India, where they've done some randomized clinical trials of clinical breast exam screening. So a clinical breast exam for screening purposes entails this very structured, meticulous, grid-like exam of the breast and the axilla in an asymptomatic person. Cervical cancer screening is another very important example of a commonly used screening test. So what's happening with cervical cancer screening? Is there any population-based cervical cancer screening in Haiti, or is it more kind of multiple different kinds of campaigns in different areas of the country?
Yes, it's the latter. Because of not national screening politics, or no relevant national screening politics. There's no campaign on the national scale. But I think for cervical cancer screening, we have a few organizations like ZL, which I work for, and I know that they do that. I want to say routinely, but this is a service that they provide much more than, let's say, a breast cancer screening. And I know for a fact that HIV female patients are routinely screened. I mean, yes, this is a targeted population that is more closely followed for that.
Great, thank you. And do you know what kind of screening they're doing?
It's mostly VIE.
Got it, okay. Okay, yeah, so that's what we're doing in the PIH supported districts in Rwanda as well. So the three most common screening strategies initial screening strategies are HPV testing. So we're looking for the presence of HPV DNA, either in the cervix or the vagina. HPV testing in the vaginal canal is great, in my opinion, because you don't need to do a speculum exam, which requires more materials and is more uncomfortable. And also vaginal HPV testing can be self-performed by a woman, and that has been shown to be really acceptable to women in many different settings. HPV testing is increasingly, I think in about 5 years in the United States, we will be using primary HPV testing as our only screening strategy for women in the United States. But it's taken us a while to get there. But it is definitely the most sensitive of these methods. The second option is visual inspection with acetic acid, which that's what you're doing now. And as you know, that's when you apply acetic acid or vinegar to the cervix and look for different, I have a slide that shows this, but different adhesion of the acetic acid to lesions that might represent precancer. And then pap smears, which is cytology testing, much less sensitive than HPV testing, requires more testing than HPV testing, and requires you to have a cytologist on site. So is typically sort of outgoing, I think, in many, and not the testing of the future in most low and middle income countries. So if an abnormality is detected, we have several treatment options. One of them is cryotherapy or thermoablation, which are both local and potentially immediately available strategies to test an abnormality. And then excision with something like LEAP is another option. But the goal here, as we talked about before, is to find a precancer and treat that precancer so that it never develops into cancer. We talked about this, but I think it's sometimes helpful if people haven't done VIA to actually see what a VIA positive lesion looks like. So you can see that the acetic acid creates this very opaque white area in the abnormalities. So this is Rwanda's one of Rwanda's screening strategies. So in areas where they have HPV testing, which unfortunately is expensive and so isn't available in all districts of Rwanda, we don't need to go into detail, but they use the HPV testing as their primary, their initial test, and do VIA only on those who are HPV positive. The advantage of doing this, of course, is that you have to do, because HPV testing is so sensitive, we can be pretty sure that someone who tests HPV negative is not going to have a cervical precancer. And so we only have to do VIA on people who are HPV positive. So it's more efficient. It spares women, it potentially spares women speculum exams and unnecessary testing or treatment. I wanted to just talk a little bit about PSA screening. I'm sure PSA screening isn't happening routinely. This is for prostate cancer in Haiti. Do you know if it's ever happening for select groups?
Not sure. I mean, not extensively.
Yeah, like
Probably
maybe in a
yes.
private clinic or something.
Yes, probably yes, private clinic. And yes, it's not because it has to be done in Port-au-Prince and private, and patient has to pay out of pocket. So because of those, it's almost the same situation as mammogram. It's more often, I mean, when patient have symptoms that we look for.
Yeah, that makes
There's
perfect
no-
sense. Yeah, so you guys probably do. And so do you do PSA testing at Mirabelais if someone has symptoms of prostate cancer?
Usually, no, we refer to sonogram or biopsy.
Got it.
Yes, and yes, I guess some people yes can ask PSA in the workup.
Okay.
But since there is no, I mean, comprehensive guidelines for prostate cancer care, I would say, though there's no standardized, yes, treatment
Yeah,
method
okay.
or screening method or diagnosis method.
That's helpful, thank you. So the PSA is a protein produced by, is prostate-specific antigen. It's a protein that's produced by prostate gland cells. It can be produced by normal cells, and then it's produced as well by malignant prostate gland cells. It's elevated in prostate cancer, but one of the tricky things about PSA is that it can also be elevated in benign conditions, including benign prostatic hyperplasia or BPH, as well as in any inflammation of the prostate. So we certainly use it for monitoring. In the United States, for example, we do use it for monitoring of people who have prostate cancer to assess for recurrence. And we do use it in select situations for screening. We used to use it really widely, but because a high PSA is not necessarily indicative of prostate cancer, screening with PSA can lead to unnecessary biopsies. And then the other major issue that's become increasingly clear is that it can lead to a lot of overdiagnosis. So prostate cancer is like many cancers, is a very biologically heterogeneous disease, with some being very indolent, many being very indolent. And so if you diagnose a prostate cancer because of an elevated PSA and you subject the man to treatment, we now know that it's very common that that cancer that you treated him for would never have caused him any problems. And the treatment can be really toxic and difficult to tolerate and have a profound impact on health and quality of life. And so there has been a lot of concern that if you screen with PSA routinely, you're going to treat a lot of people unnecessarily. So again, similar to breast cancer, the screening world is continually trying to develop strategies to identify the people who are the best candidates for screening, the most likely to have an aggressive prostate cancer, and the most likely to actually benefit from screening rather than experiencing harm. Any questions about this?
No, it's clear.
Excuse me, I have a question about the prostate cancer.
Yeah.
At what age we can stop the screening for this patient, for example, for prostate cancer?
To start.
Stop
Oh,
it.
Stop screening?
Yeah.
Is there a stopping age? I think probably, well, so increasingly we're stopping screening at, we're trying to tailor our stopping for when someone has like a less than 10-year life expectancy, for example. I think probably guidelines in the US, you stop in the 70s. Scott, do you know what it is? Or Sarah?
We usually stop around 70. Depends sort of on their comorbidities and like what else is going on with them.
Yeah.
And yeah, but around 70, unless some men really want to keep doing it. But
yeah, that's what we do as well. I mean, it varies from patient to patient depending on risk classifications, but in their 70s generally.
But good question. And yeah, that's an area of tremendous controversy when to stop screening. So, the likelihood of over-diagnosing a cancer, so diagnosing a cancer that never would have caused problems, increases as someone gets older, because we'll talk about this in a couple of slides, but if you diagnose a cancer in an 80-year-old man who is going to die of a heart attack at 85, if you diagnose a very, very small cancer, chances are he's going to die of his heart attack before that cancer causes any symptoms. So screening, and so, if you were to diagnose a prostate cancer and you do a prostate biopsy and he gets a UTI, gets urosepsis from the prostate biopsy, he has pain, he endures treatment, and he has issues from the treatment, all of that, you've put him through with no benefit at all, because that cancer never would have caused him problems. So the likelihood of causing more problems than benefit actually increases with old age. So colon cancer screening, I just wanted to provide a few examples here. Sorry that this slide is kind of small text. Colon cancer screening is complex in the United States. The gold standard for colon cancer screening has always been colonoscopy, so endoscopy of the colon. And historically, guidelines in the US were to start at 50. And then if the colonoscopy was negative in an average risk person, we would do a colonoscopy every 10 years. Uptake of colonoscopy, and again, the goal is to detect a polyp, like an adenomatous polyp that could potentially become cancer in the future, and can be removed, thereby preventing cancer, or that you detect a small, early invasive cancer. And we have seen, though not through any randomized controlled trials, but through observational studies, we have seen a reduction in colon cancer incidence and mortality with colonoscopy screening. However, uptake is pretty low for a lot of reasons. Nobody wants to go through a colonoscopy because you have to do an intensive prep where you clean out your colon beforehand. It's an invasive procedure. But then also access is fairly limited. It needs to be performed by a highly trained specialist at a specific site. And even at Brigham and Women's, there's you have to wait about 6 months to get your colonoscopy screening right now. So increasingly, there's been research into stool-based tests. Previously, we just had fecal occult blood tests, which are guaiac-based. They detect the presence of blood. Increasingly, we have more sensitive fecal occult blood tests that are based on immunochemical evidence of blood, or the FIT test. There's also a stool-based test that looks at tumor DNA and can be done every 3 years. And these stool-based tests, so they require patients to collect their own stool sample, and they can either mail it into the clinic or bring it in. Those stool-based tests are much more accessible to patients and more acceptable to many patients. So they do have the potential of allowing broader uptake, including population-based screening. However, they do require, like everyone who has a positive stool-based test, so there's evidence of blood or tumor DNA in their stool, everyone needs a colonoscopy. So there has to be a system in place to make sure that all of those positive tests, all people with positive tests get a colonoscopy. And you have to make sure you counsel your patient that if they have a positive test, they need a colonoscopy. And if they absolutely will not get a colonoscopy, then they shouldn't get the stool-based test. Any questions about colon cancer screening? So the typical protocol in the US would be to test, so the recommended ages has gone down. So now it's 45, starting at 45 and then ending when someone has about a 10-year life expectancy remaining. Any questions about these screening tests?
Not from my end.
Okay. And we'll have time for questions at the end as well. So potential harms of screening, we've talked about these a little bit, but they're really important. So I wanna just go through them more systematically. So you're subjecting a large proportion of people to a test. These tests can be of varying degrees of discomfort. For many people, for many women, having a pelvic exam can be incredibly uncomfortable. If a woman has experienced trauma previously, it may be traumatizing. A large proportion of people are going to have the test, but only a few are going to benefit. And so there's also costs. There may be costs for patients, and that can be particularly profound in a setting with high rates of poverty. False positive results is a very important consequence of screening. So often many people will have a false positive result, which means that they'll have an abnormal test that does not ultimately lead to a cancer diagnosis. And that patient is going to require further testing, including potentially biopsies. So we see this a lot with breast cancer screening in the United States. For example, if you screened 1,000 women every year with a mammogram, about half of them over those 10 years will have a false positive result. And that means that the radiology clinic calls the patient, tells her that she has an abnormal mammogram and she needs to come back for another mammogram, sometimes 2 more mammograms, an ultrasound, and then about 10% of those women will have a biopsy, and then they're told that they have something like a fibroadenoma and don't have cancer. So they don't experience actual risk from those procedures, but they can experience a lot of anxiety and distress. There may be a lot of cost to the patient, there's cost to the healthcare system, and it may impact her willingness to be screened again. We've talked a bit about overdiagnosis. Oh, any questions about false positives? So overdiagnosis is a really important concept that sometimes people mix up with false positives. But remember that false positives occur when you when the test result is abnormal, but there's no cancer. Overdiagnosis happens when the test result is abnormal and you are diagnosed with cancer, but that cancer never would have caused you any problems. So this is more likely to happen in a few situations. So one, you detect a cancer that is very, very slow growing or not growing at all, as is the case with many prostate cancers, but is also the case with some breast and even some lung cancers. So you tell the patient they have cancer, you treat them for cancer, but they're either going to live a long, healthy life otherwise, or they're going to die of something else before they would have experienced any symptoms from that cancer. So you have not helped them by treating them for cancer. And we know this is a big issue.
Yes,
Sorry,
I would like to take a second just to translate that to the team.
Oh, yeah.
I think that's an issue we rarely take in account, or yes, and that may be a little bit hard to grasp for us.
Yes, please.
Mwen te ve traduit parti sa que Lydia fait tout parler à, qui c'est que gen des fois gen des faux positifs. Donc ça veut dire que test nan montre que moun nan gen cancer alors que moun nan pas gen cancer vrai. Mais ça n'a pas laissé qui comme si dommage ka gen nan fait screening là que par exemple moun nan gen un cancer ou fait diagnostic cancer là obligé traiter moun nan. Or, son cancer qui pas tapal ben moun nan des problèmes le temps que il vivre là. Par exemple, cancer prostate, un cancer qui évolue relativement lentement. L'on fait diagnostic là, ou ka ben moun nan biopsie, faut faire biopsie, et des fois faut faire chirurgie, faut faire chimiothérapie. Parallèlement, moun nan te capable juste vivre avec ces cancers là qui pas capable déranger du tout et puis il est capable mourir de tension, de stroke, ou bien de crise cardiaque. Donc, ça, c'est important. Ça fait bien des fois, pour prendre ça en compte dans le screening. Il y a des cancers qui évoluent lentement, qui ne pas déranger. Thank you.
On connaît, Dr. Lomil, culture par nous, on connaît les causes des problèmes parce qu'en Haïti, des produits cancer, on connaît, bon, nous vivons ça même là, avec situation, on connaît juste venir les gourmets, les tous ces chimiothérapies, le besoin. Ça veut dire depuis que tu as cancer, ça veut dire les gourmets, mais pour la France, de toute façon, depuis ces cancers liés, il faut le jeune traitement, peu importe. La pays, c'est comme si exigence civile pour connaître là, pas j'ai l'impression avec le côté, qui ne pas trop comprendre. Peut-être pour dire que c'est pas grave, les cas vivent ensemble avec elle, etc.
Et justement, maintenant, la bonne question que vous posez, est-ce que dans le cas ça, est-ce que vous ne pouvez pas traiter? Bon, me poser Lydia question ça. Yes, Lydia, so what Manley said is that, yes, he said that is an issue because when you tell the person the diagnosis, they will normally, as expected, ask to be treated. And I have a question regarding what he just said, is that on those situations, when you know that is a slow progressing cancer, and that you know that the patient has a low life expectancy, how is the approach regarding non-treatment? I know that is always an option, but is that recommended? I mean, are there specific recommendations that with that diagnosis, you just decide not to treat? I mean, also is that recommendation?
That's a great question. I'll answer half of it. So if in the screening context, so that's when you've run a test on someone who does not have symptoms, right? So you're looking for something that is not causing them problems. So if you have a patient in whom you wouldn't want to treat a cancer, so for me, that would be my 80-year-old patient with advanced heart disease, I should not do the mammogram, right? If she doesn't have any symptoms, she doesn't have a breast lump, she doesn't have unexplained weight loss, I shouldn't do the mammogram if I wouldn't recommend treatment for something I found. Now in the treatment, so in the context of working up symptoms, it gets a little more complicated, and I would probably have my patient talk to an oncologist it certainly happens that, so with prostate cancer, for example, and Scott can talk about this, but we certainly have protocols where if we diagnose prostate cancer, we sometimes can identify based on tumor characteristics that this is a low-grade cancer. And same thing with breast. Sometimes we'll diagnose ductal carcinoma in situ, so a low-grade pre-invasive breast cancer that we can, based on evidence, we know that that cancer is unlikely to progress and unlikely to cause them problems before they die. And then we can counsel the patient and we can implement watchful waiting, where we maybe do periodic PSA checks, clinical breast exams, and just keep an eye on them. But that requires a lot of counseling with the patient. Scott or Dio or Sarah or anyone, do you guys have any more comments about that? I mean, so I'd say from a screening standpoint, you should not be screening someone who you don't think is a good candidate for treatment.
So I can jump in about prostate cancer. Certainly, this situation comes up all the time where we have a gentleman, say in his 70s, who has multiple comorbidities. And by the actuarial tables that we have, we know that their life expectancy may be 5, 7, 9 years. And certainly with a less than 10-year life expectancy for a patient with prostate cancer, you don't want to diagnose their prostate cancer, put them through potentially morbid procedures to confirm the diagnosis, and then put them through treatments that have morbidity attached to them and significant cost. It really has to be tailored to the individual. Certainly there are some 70-year-olds with a 15, 18-year life expectancy. There are others with a 5-year life expectancy. So it's not one size fits all. You can come up with some rules to guide you, but you're opening up a real Pandora's box with some of these patients when you're overly aggressive in terms of your screening in an inappropriate population.
One thing I'd say is that is very interesting to me as a non-oncologist, but historically, part of the reason that overdiagnosis happened is that we had such a hard time. If we diagnosed cancer, we treated someone for cancer. We had a hard time knowing which cancers are the bad cancers and which cancers aren't going to cause problems. But our ability to differentiate between bad cancers and less aggressive cancers has improved a lot. And my sense is that prostate cancer we do that pretty better and better. We're able to differentiate between the most aggressive tumors that are likely to cause problems for a patient given their life expectancy and those that are not. And so we've gotten better at counseling, at detecting, at identifying which cancers need to be treated, identifying which ones can be watched, and counseling patients about that. And my sense is that we are getting better at that with breast cancer, but that we're not quite there yet. We're not at a place where we do watchful waiting for a 70-year-old with most breast cancers. Dio, I don't know if you.
Yeah, I agree with what you said, Lydia. However, the type of treatment might be different depending on, what the characteristics of the cancer. So, the way non-aggressive cancer in a 70 or 80-year-old might be approached might be different. And I think we have some of that in the way the protocols are currently written in Haiti, in which case that patients might either only get lumpectomies or only get mastectomies and not have any further treatment, or only get hormonal therapy and not get chemotherapy. So there are ways of tailoring the treatment to the type of cancer as well. Ruth, you raised your hand. I don't know if you still had a question or comment.
Yes. Yes. So what I wanted to say is overdiagnosing or having patients that shouldn't receive treatment is something that we almost never see in Haiti. Mostly people want treatment. Mostly people, they are in need of a treatment. So it's not really a problem. The only situation that we have a cancer diagnostic and we don't give a treatment, but it's not screening, it's CLL. So we have a few CLL patients, and it's been very difficult, but hopefully, I think we have four, we had four, but one progressed and is very sick now. But usually it's difficult to explain to this patient that you do have a cancer, but it's real, you don't need a treatment. We just need to monitor your condition. And then if you need a treatment, then we'll give you this and that. So it's very difficult, like Castel said, for Haitian nationals to tell the person that you have cancer, but we're not going to treat you. We're going to watch you, and if you need treatment, then you'll treat. This is the only condition in my experience that I had to tell a patient that you have cancer, but no treatment. But otherwise, for breast cancer and prostate cancer, it's very different from in the US, because in the Black population, the prostate cancer tend to be more aggressive. And there are some studies about the Caribbean population. So we have the very high mortality of prostate cancer. It's really a concern as compared to the US in the white population, where prostate cancer tend to be more indolent. So yeah, so that's why I wanted to say.
Yeah, Ruth, thank you so much. I think I was actually going to say something similar, which is that overdiagnosis is not an issue in populations that are not undergoing widespread screening. If you have a man who has symptoms from prostate cancer, you are not going to overdiagnose him if you diagnose that cancer. He's already experienced problems from that cancer. And same thing in Rwanda, we're not diagnosing asymptomatic breast cancer. We're only diagnosing breast cancers that have already caused a mass. So no one in Rwanda is experiencing overdiagnosis, and same with Haiti. I think this is an important, and actually with prostate cancer, I agree with you also, we do tend to screen our Black patients in the US more aggressively because of data that's similar to what you're describing. I would suspect that all of the prostate cancers that you're diagnosed in Haiti already cause symptoms, so presumably are more aggressive cancers. There may be many less aggressive cancers that are just not getting diagnosed because you're not overdiagnosing them. I still think that overdiagnosis is important to understand because places like the US have created a sort of obsession with screening. And so, as Haiti no doubt is going to start screening more and more as capacity increases to screening. So increases for screening. And so there may be more and more screening. So I think it's important just to know that, as you do know, that it's not, that there are some downsides. This is a slide that I can send out if it's of interest. It just kind of visually demonstrates how overdiagnosis can happen, but I won't belabor the point. I can add it into my other slides and send it out. Oh, sorry, I didn't mean to stop sharing. Okay, so you're seeing this potential harm slide, right? Okay, so the last harm, just to mention, is that there are some potential harms from the screening test itself. We talked about discomfort from the pelvic exam of cervical cancer screening. Colonoscopy can have rare complications, including perforation of the colon, and that occurs more commonly in elderly patients. So is another reason to think carefully about cancer screening in elderly patients. I wanted to just, so many years ago in 1968, the World Health Organization identified some principles of early disease detection that I think remain really true for cancer screening. So as countries think about how to implement screening and which diseases to screen for, these are sort of the conditions that or the principles that they recommend following. So first, the condition has to be an important health problem, right? So you're going to subject a lot of people to a screening test, and only some are going to benefit. So it has to be an important enough problem to merit subjecting people to that test and also merit the costs. There has to be an accepted treatment for patients with the disease, and treatment has to be more effective at an earlier stage. Facilities for diagnosis and treatment should be available. And I put this in bold because in Rwanda, this is really our tied for #1 problem that we're facing with breast and cervical cancer screening, that you really have to make sure that for all the patients who have a positive screen, they have to receive timely evaluation, timely diagnosis, and timely treatment. And it has to be accessible, it has to be affordable. Patients have to have a way to get there and be supported in getting there. Otherwise, you should really be thinking about whether you should be doing widespread screening. There has to be a recognizable latent, so pre-symptomatic or early symptomatic stage. So there has to be a period of time in which you can, in the natural history of the disease, in which you can identify asymptomatic or early symptomatic disease. So a really aggressive tumor that goes from nothing to a very large mass really quickly is not a good candidate for screening because there are fewer opportunities to catch it early. There has to be a suitable test or examination that is acceptable to the population. It's interesting, I think colonoscopy is an example of a test that, although it works really well, is not highly acceptable to the population. So it hasn't been the most successful screening test. It's also expensive and hard to get. These ones I think are a little bit less important, so I'm not going to go through them, except that the cost of case finding, including diagnosis and treatment of patients diagnosed, has to be economically balanced in relation to possible expenditure on medical care as a whole. And I think this is really important in settings like Haiti and Rwanda. So thinking about where breast cancer, for example, falls in the entire burden of disease. So often in all of our health systems, and especially in under-resourced health systems, if you do invest a lot of resources in one condition, you may be taking away resources for something else. So thinking about, is this where we should be putting resources right now? And then case finding should be a continuing process and not once and for all projects. So this is arguing against like a single campaign, but saying that this should be a really sustained project over time. And I think that's especially true. Like one thing I've seen in some screening campaigns is that the campaign will happen, but that the actual follow-up of abnormals is much less, follow-up of those who have had abnormal tests is much less robust. You've all heard or learned about how to assess screening test performance. I'm just going to go through this briefly, but you hear a lot about sensitivity, which is the likelihood that someone who has cancer has a positive test. This is probably the most important test characteristic for a screening test. So you want there to be very few false negatives. And that's why the HPV test is such a nice screening test for cervical cancer, because if you're negative, you really are negative. It's very unlikely that you will develop cervical precancer or cancer if you have a negative HPV test. On the other hand, specificity is also really important. So the specificity is a chance that a person without cancer has a negative test. The inverse of that is the likelihood of having a false positive result. And we do see a lot of false positives with HPV testing, for example. HPV, as you know, is incredibly common. So a lot of people who have HPV and have positive HPV tests and thus get further testing like VIA, a lot of those people are not going to end up with cancer. The positive predictive value is the chance that a person with a positive test has cancer. This depends on the test characteristics, but also depends on the underlying prevalence of disease. The negative predictive value is the chance that a person with a negative test does not have cancer. I just want to mention briefly the metrics that we typically use to know if a screening population has helped a population. The gold standard here is to look at cancer-specific mortality rates, and that's what we looked at, for example, in all randomized controlled trials of mammography screening for breast cancer. We looked at whether women who were screened with a mammogram had a lower likelihood of dying from breast cancer. If in cases where a screening test can actually be preventive, so where we're looking for a pre-cancer, you may actually see a reduction in cancer incidence. So we've decreased the number of precancers that become cancer because we've removed them. But these results are really hard to interpret if you're only looking at observational studies where you didn't randomize people to receive a screening test and then compare a totally screened versus a totally unscreened population. I don't think we need to go into this a lot. We've talked about a lot of this, but this is really just the metrics that we look at when we're identifying if a screening program has helped the population. You have to take into account the adverse effects of screening that we've talked a lot about. You should ideally take into account the adverse effects of treatment, especially unnecessary treatment. And ideally, you're looking for reduced disease-specific mortality. I'm not going to go into this because we talked about this. I wanted to just spend 1 minute on early diagnosis. We talked about this a little bit, but early diagnosis is the identification of symptomatic disease at an earlier stage. And that's really what we're working on in Rwanda, trying to bring in women who have breast masses or other breast symptoms sooner than they were coming in before. And that is not screening. So that's early diagnosis. It still could have some potential harms, but has a lot fewer harms because you can have a false positive. So you can certainly examine their mass, subject them to a biopsy and diagnose a fibroadenoma. But the ratio of benefits to harms is more favorable, and overdiagnosis doesn't exist in this context. Are there ways in which your team is working on early diagnosis for any cancers?
Yes. Lydia, there's something I wanted to talk about is self-breast exam. I know it's not a tool that is used in most countries, and there are no studies to support it. But in Haiti, because we've been seeing so many cases, very advanced cases, and many patients will say, I never saw the mass before, or someone else, like my daughter saw it while I was something. So we decided to use self-breast exam as I mean, it's not easy to put a name on it, but we really use it. So we developed a tool that was used in somewhere in Florida. So we adapted it. So we have like a guideline explaining how to do self-breast exam, in what period you should do it, like 1 week after your period. So in every month, and they have like a door hanger, and every time they do it, they can press it so they can know that every month they do it. So because we didn't do any studies, we don't know exactly what that will do. But every time we have a public awareness activities, like in October or in February for World Cancer Day, we will distribute those door hangers and explain to the public how to do self-breast exam. So I know it's not recommended, but we've been doing it.
We do it too. We do. We encourage more of a. So I would say that it's not recommended. It's not recommended in the United States anymore in a context where we have mammography. You know, in settings where you don't have mammography, there is some evidence that screening clinical breast exam is beneficial. I think in terms of self-breast exam, it is true that there are some randomized controlled trials that do not suggest a benefit. And that's partly because breasts are lumpy. There are more false positives that way. Increasingly, we advocate for a breast self-awareness approach where we encourage women to know what their breasts feel like normally and then to be able to identify a change. I think if you teach every woman in your community how to do a self-breast exam, what we see in Rwanda is that the women who tend to take on that message the most are often the younger women who are at lower risk of breast cancer. And so from my point of view, the biggest downside is that there is the possibility that you will bring a lot of women into the system who are at low risk. And then you might potentially divert attention from higher risk populations and maybe use healthcare resources on women who are at lower risk. But I still think that I believe that there is a lot of benefit to the stigma reduction, to normalizing breast self-awareness. Those women someday are going to be 40 and 50 years old, and they may identify their breast cancer sooner. So I do think there's benefit. What we've really been trying to understand in Rwanda is when you do things like that, what is the impact for the healthcare system? Like, who is your target population? Should you be really targeting older women? How do you engage older women? But I think in a setting where you don't have mammography screening, it makes sense certainly makes sense to focus on awareness. It certainly makes sense to build healthcare capacity, health system capacity to diagnose symptomatic disease efficiently. So everyone needs to know how to do a high quality clinical breast exam.
Thank you.
So we're getting to the end of the hour. So just want to bring that up if folks have any last questions or comments.
And Ruth, I'm always happy to brainstorm about this stuff with you.
Okay, well, if no further questions, thank you very much, Lydia. This was fantastic, very, very educational for me, and I'm sure for a lot of folks on the call as well. So thank you.
Thank you all. Happy New Year. Take care.